Hello everyone, welcome back to this series of lectures in nephrology. In the last session we had learnt about your approach to glomerular nephritis and nephritic syndromes. In today's session we will be learning about nephrotic syndromes. So before we move on to our understanding of nephrotic syndromes, let us understand the structure of the filtration barrier. So the filtration barrier basically comprises of three portions. One is your glomerular basement membrane, the other is the endothelium which lines the glomerular capillaries, and we have the third one which is your visceral epithelial cells. The visceral epithelial cells and their foot processes which are also called as your podocytes. So we have your visceral epithelial cells and the foot processes which are also called as your podocytes. So these podocyte foot processes along with your glomerular basement membrane and endothelium are the ones which comprise of the filtration barrier. So what is the importance of this filtration barrier? The importance of this filtration barrier is that this is size as well as charge selective. This is size as well as charge selective, right? So let us take this example of this molecule albumin. So the albumin is negatively charged. So the negatively charged albumin is repelled by the negatively charged glomerular basement membrane. So this ensures that there is no albumin leak into the urine. So in the normal conditions there is no proteinuria. Okay, fine. That is the importance of the filtration barrier. Now if you zoom in this further, you can see the structure of the podocyte. Each podocyte is connected to one another by these cytoskeleton elements which are known as nephrin. Apart from that, you also have this protein called podocin, and the podocytes are connected to the glomerular basement membrane by the proteins called integrins. So what is the importance of all of these proteins? These proteins, when they are affected, it basically results in your congenital nephrotic syndromes. It results in your congenital nephrotic syndromes. Okay. So this is about the basics of the structure of the filtration barrier and about your various proteins involved in the formation of the filtration slit. So this particular portion is called as the filtration slit or your slit diaphragm. Fine. Now let us move on to the first type of nephrotic syndrome, which is your minimal change disease. So the first type of nephrotic syndrome is your minimal change disease. Now, minimal change disease is the most common cause of nephrotic syndrome in children. So the minimal change disease is the most common cause of nephrotic syndrome in children. But in adults, if you are suspecting a minimal change disease, you always have to do a renal biopsy and always rule out secondary causes. So in a child presenting with nephrotic syndrome, you can directly treat them as minimal change disease. But an adult presenting with nephrotic syndrome, you always have to do a renal biopsy, and if it comes out as minimal change disease, always look for secondary causes. So what are the secondary causes for minimal change disease? It includes drugs like NSAIDs, interferon alpha and gold, and always remember to rule out malignancies like Hodgkin's lymphoma, and sometimes even allergies including bronchial asthma can predispose to minimal change disease. Okay, so this is about your etiologies of minimal change disease. So always remember, in a child presenting with nephrotic syndrome, you can directly treat the patient as minimal change disease, but in an adult, always do a renal biopsy and rule out the secondary causes for MCD. Now what do you find on your biopsy? On light microscopy, what do you find is it is minimal change, so there are no visible changes seen on the light microscopy, or the light microscopic findings are normal. On the electron microscopy, on the other hand, you can find effacement of podocyte foot processes. You can find effacement of podocyte foot processes. So you can find effacement of podocyte foot processes. Now before we move on to the management of MCD, we should be understanding certain terms which are associated with these nephrotic syndromes. So the first term is your remission. So what is remission? Remission is defined as a urine protein creatinine ratio. Urine protein creatinine, UPCR, is your urine protein creatinine ratio less than 0.2 gram per gram for 3 consecutive days. So the UPCR is less than 0.2 for 3 consecutive days when the patient has been on treatment for nephrotic syndrome. The second term is your steroid responsive nephrotic syndrome. So the cornerstone of management in your minimal change disease is your steroids. So a steroid responsive nephrotic syndrome is defined as a response obtained by a dose of prednisolone at 60 mg per meter square body surface area per day within 4 weeks of treatment. So if the response or remission is obtained within 4 weeks of treatment of prednisolone, then this is called as a steroid responsive nephrotic syndrome. Now, what is a steroid resistant nephrotic syndrome or SRNS? So what is a steroid resistant nephrotic syndrome? No remission is obtained by the same dose of prednisolone of 60 mg per meter square body surface area per day within 4 weeks of treatment in a child or 16 weeks of treatment in an adult. So there has been no response in treatment with prednisolone for 4 weeks in a child or 16 weeks in an adult. That is, even after this much of treatment, the urine PCR continues to be positive, then it is called a steroid resistant nephrotic syndrome. Now let us understand what is this FRNS or your frequently relapsing nephrotic syndrome. So in this FRNS, what happens is that there are more than 2 relapses in 6 months or more than 4 relapses in 1 year. So there are more than 2 relapses in 6 months or more than 4 relapses in 1 year. What is your steroid dependent nephrotic syndrome or your SDNS? There are 2 relapses under standard therapy or relapse during tapering of the drug or within 2 weeks of stopping the drug. So in your nephrotic syndrome, once you start them on steroids, in children you treat them up to 4 weeks or in adults you treat them up to 16 weeks, right? So during the tapering of the steroid or within 2 weeks of stopping the drug, if there is a relapse and the UPCR becomes positive, then it is called as your steroid dependent nephrotic syndrome. Okay. So I hope we are clear with the terms. We have understood what is remission, what is steroid response, what is steroid resistant, and what is frequent relapse, and what is steroid dependent nephrotic syndrome. Now let us move on to the management of minimal change disease. So the management of minimal change disease involves steroids. So that is the cornerstone of management. In children, prednisolone is given at a dose of 2 mg per kg per day. In adult, it is given at a dose of 1 mg per kg per day. And the duration of treatment is for up to 12 weeks. Now, in steroid resistant nephrotic syndrome, now if the patient becomes a steroid resistant nephrotic syndrome, that is, the UPCR is positive in a child beyond 4 weeks of treatment or beyond 16 weeks in an adult, then we are dealing with a steroid resistant nephrotic syndrome. And in a child or in an adult, you definitely have to do a biopsy. The treatment will be calcineurin inhibitors or levamisole. So you do a biopsy in a child because in a child you preemptively treat them as minimal change. So you do a biopsy and it still shows minimal change, then you are dealing with your SRNS and treat it with calcineurin inhibitors or levamisole. Now what happens to your FRNS or your frequently relapsing nephrotic syndrome? So most of the time the FRNS is usually precipitated by an upper respiratory tract infection. So it is suggested that in children, every time they have an upper respiratory tract infection, you give them steroids for about the 4 to 5 days of your upper respiratory tract infection at a dose of 0.5 mg per kg. So you give them steroids during your upper respiratory infection. Fine. The second line management will be with your cyclophosphamide and it is given for 12 weeks. So this is about your minimal change disease. So what are the key points we have learned till now? We have learned about minimal change. How does it present? How do you treat it in a child? How do you treat it in an adult? What are the indications for biopsy in minimal change? And we have understood the management as well. So let us move on to the next type of nephrotic syndrome, which is your FSGS, which stands for focal segmental glomerulosclerosis, which stands for focal segmental glomerulosclerosis. So, this particular FSGS is basically a pattern that you obtain on your biopsy. So, this is basically a pattern that you obtain on your biopsy, and FSGS does not refer to any particular cause. So, every time you find an FSGS pattern, you have to think of the cause for your FSGS. And always remember that 2/3 of the cases actually progress to CKD, hence the prognosis is poor. Prognosis is poor. So, what is the pathogenesis here? So, here also you have effacement of podocyte foot processes. Yeah, but there is also a decrease in the podocyte number. The decrease in podocyte number is not seen in your minimal change. So, that is how FSGS is different from minimal change disease. Now, let us understand the etiologies for your FSGS. So, it can be classified as your primary and your secondary. Under your secondary causes, always remember adaptive response to hyperfiltration. For example, in a patient who has one non-functioning kidney, the other functioning kidney has a hyper-responsiveness and they undergo hyperfiltration. So, as an adaptation to hyperfiltration, you can develop secondary FSGS. Secondary FSGS is also associated with obesity. Then, remember the viruses HIV, hepatitis B and parvovirus. Then, hypertensive nephropathy and reflux nephropathy. Remember the drugs, heroin, analgesics and bisphosphonate use. Apart from that, sickle cell anemia and radiation nephritis. So, this is about the various causes for FSGS. And remember that we have learnt about your congenital nephrotic syndromes, where you have your familial causes for your FSGS. This includes your nephrin and podocyte mutations, which is your NPHS1 and NPHS2 mutations. Apart from this, Wilms tumor gene, TRPC6 cation channel, alpha-actinin mutations, all of these can result in your congenital nephrotic syndromes. Okay. So, I hope the etiology of FSGS is clear. Now, let us understand the microscopic findings and the variants of FSGS. So, the first variant is your perihilar variant. That means where the glomerulus arises, you have the hilum and you can have a perihilar variant. Then you have a tip variant. The tip variant has the best prognosis. The third variant is your collapsing variant. In this collapsing variant, what happens is that there is proliferation of the parietal epithelial cells and it results in the formation of this crescents. There is a formation of these crescents. So, what happens is that these crescents exert a pressure on the glomerulus and cause collapse. So, this collapsing variant is associated with HIV, parvovirus and interferon alpha. So, the collapsing variant of FSGS actually has a poor prognosis. So, we can understand that the collapsing variant actually has a poor prognosis. Fine. So, this is about your variants of FSGS. Now, let us understand what do we see in your light microscopy findings. So, in your light microscopy findings, what do we see? So, we see that there is a focal and segmental injury. Focal means only some portions of the glomeruli are involved, and segmental means that only some portions of the total glomeruli are involved. So, there are focal and segmental involvement of the glomerulus. So, there can be expansion in the mesangium as well, and there can be hypercellularity in focal parts of your glomeruli. In your immunofluorescence, you can have focal IgM and C3 deposition. In your electron microscopy, can you see that some of parts of the glomeruli are collapsed, some of the parietal epithelial and visceral epithelial cells are detached. There is detachment of the podocytes from the glomerular basement membrane. There is a decrease in the number of podocytes. There is a decrease in the number of podocytes, and the subepithelial cells can also proliferate. So, you can see that only one part of the glomerulus is involved. So, this is your FSGS. So, what is the treatment? Treatment is treatment of the underlying cause, and treatments include steroids and calcineurin inhibitors. So, you treat the underlying cause and you also treat with steroids and calcineurin inhibitor. So, that brings us to the end of focal segmental glomerulosclerosis. Let us understand the third type of glomerular or nephrotic syndromes, which is your membranous nephropathy. Now, membranous nephropathy is also a pattern. So, whenever you get a membranous nephropathy, always think of what is the cause for this membranous nephropathy. So, 1/3 of the cases actually progress to CKD. Primary membranous nephropathy is usually associated with your phospholipase A2 receptor antibody. So, a patient presenting with nephrotic syndrome and the PLA2R receptor antibody is positive, then it's directly a primary membranous nephropathy. Always remember that the membranous nephropathy is the type of nephrotic syndrome which has the highest risk of thrombosis. So, what are the secondary causes for membranous nephropathy? It includes infections like hepatitis B, C, syphilis, malaria, schistosoma, solid organ cancers including breast, colon, kidney, esophagus, drugs like gold, mercury, penicillamine, interferon alpha and NSAIDs, autoimmune diseases, and certain other systemic diseases like sickle cell, diabetes, sarcoid, IgG4 related diseases. So, this is this huge vast list of causes for your secondary membranous nephropathy. Now, let us understand the microscopic findings of membranous nephropathy. So, the microscopic findings include light microscopy. You can have increased thickening of the glomerular basement membrane. Your immunofluorescence is again a granular pattern of IgG and C3, IgG4 and C3 in your capillary wall. If there are mesangial deposits, it's usually of IgG1, and if mesangial deposits are present, it points more towards your secondary membranous nephropathy. So, can you see in the electron microscopy, you will have subepithelial deposits, and sometimes there can be fusion of the foot processes as well. So, what is the treatment of membranous nephropathy? Treatment includes a regimen which is called as your modified Ponticelli regimen. In this regimen, in your months 1, 3 and 5, you give steroids, and in the other months you give cyclophosphamide. So, we give alternating steroids and cyclophosphamide. Steroids are given for 28 days every month in the months 1, 3 and 5, and in the months 2, 4 and 6 you give oral cyclophosphamide. So, this is about your membranous nephropathy. So, with this we have understood what are the different types of nephrotic syndrome. Now, let us move on to your rapidly progressive glomerulonephritis. So, rapidly progressive glomerulonephritis basically comprises of this. So, this comprises of progressive facial puffiness, pedal edema, oliguria and hypertension. So, what is rapid in this? So, there is a rapid deterioration of your renal functions, rapid fall in your renal function, right? So, within 2 to 3 days, they can even become dialysis dependent. So, this is your rapidly progressive glomerulonephritis. So, what are the clinical hallmarks? It has progressive facial puffiness, pedal edema, oliguria and hypertension. So, if you do a biopsy in these patients, what will you get? You will get this crescentric or your collapsing glomerulonephritis. So, any patient who presents with a rapidly progressive renal failure, you have to think of RPGN. So, what are the types of RPGN? The types include type 1, where there is a linear IgG-C3 deposition. So, every RPGN you definitely have to go ahead and do a renal biopsy, because the patient will be very sick. If you have to preserve the kidney, you have to do a renal biopsy. So, based on the biopsy, this RPGN is classified as your type 1 RPGN, where you have linear IgG and C3 deposition, right? For example, this is your Goodpasture syndrome. Then in your type 2, you have your immune complex deposits. Immune complex deposits including SLE, adult onset henoxylin purpura and membranoproliferative glomerulonephritis. So, type 2 is your immune complex mediated rapidly progressive glomerulonephritis, where you can have immune complex depositions as seen in SLE, adult HSP or MPGN. Type 3 is your pauci-immune, where in your immunofluorescence is negative and you do not have any deposits. So, this is seen in your ANCA associated vasculitis. So, the treatment of RPGN basically involves dialysis support because they have rapidly progressive renal failure. Do a renal biopsy, find out the cause. Is it your type 1, type 2 or type 3? Depending upon the etiology, you may have to do a plasmapheresis as well. plasmapheresis as well. Okay. So this is about your rapidly progressive renal failure, RPRF, under which we have your RPGN. Now let us understand this syndrome, which is your Goodpasture syndrome. So Goodpasture syndrome, as we have discussed, is a pulmonary renal syndrome. So this occurs because of antibodies that are directed against what? Against the beta chain of type 4 collagen, which is found in your basement membrane. So there are antibodies which are attacking the beta chain of type 4 collagen, which is found in your glomerular basement membrane. Okay. So this is basically in essential an anti-GBM disease. Okay. So why is it called a pulmonary renal syndrome? Because you have a pulmonary as well as a renal involvement in it. So what is the pulmonary component? What is the pulmonary component? The pulmonary component is that this can have a massive hemoptysis. Massive hemoptysis because of a process that we call as diffuse alveolar hemorrhage. So the antibodies which are formed against the glomerular basement membrane, these antibodies can be directed against your pulmonary basement membrane as well and can result in bleeding into the alveoli. This is what we call as the diffuse alveolar hemorrhage, and the patient can present with massive hemoptysis. The renal involvement is basically your rapidly progressive glomerulonephritis, which results in a rapidly progressive renal failure such that they become dialysis dependent in 2 to 3 days as well. How do you diagnose? One is your renal biopsy. In your renal biopsy, you will find a crescentric glomerulonephritis. The other is that you do a bronchoalveolar lavage, and this will show the presence of hemosiderin-laden macrophages. So if the BAL is positive for hemosiderin-laden macrophages, it means that there is a diffuse alveolar hemorrhage. So on your chest X-ray, how will it look? It will look like an ARDS only. It will look like an ARDS feature only. So how do the patients present? The patients present explosively with ARDS and complete renal shutdown. What is the treatment? Right? So if there is active lung hemorrhage, if the serum creatinine is less than 5.5, urine output is good and there is continuous crescent formation, that means that you can still salvage the kidney. If the kidney and lungs are still salvageable, where there is active lung hemorrhage but the creatinine is still less than 5.5 and the urine output is maintained, then you can try plasma exchange. But the final treatment would be a double transplant, which is your lung plus renal transplant. So if the renal damage has happened beyond the point and they have become dialysis dependent, then there is no point of doing a plex. You will have to do a double transplant, which includes a lung and a renal transplant. So this is about your Goodpasture syndrome. So with this, we have come to the end of our discussion on nephritic and nephrotic syndromes, and I hope you have understood the approach to glomerular disorders well. Thank you.